Hey everybody, welcome back to Spot Check. We're going to continue going over some genoderms here, and we're going to do specifically genoderms of the connective tissue disorders. As always, thanks to Sarah and Boomy for what they do and making this great PowerPoint. Give them a thank comment down below. If you have any mnemonics, any additives, any corrections, anything you want to add to the overall presentation, please leave it down below as well. Here's the overview. A lot of high yield syndromes in this, so definitely a lecture to pay attention to. One that will definitely help you out. We're going to talk about Ehlers-Danlos syndrome first, and we know that that's a heterogeneous group of connective tissue disorders. We know that there's several types underneath of that, and each type has its own potentially responsible gene, if any, etc. So I think it's better to go through them in types. So we're going to start out here with the classical type, which is type 1 and type 2. What you'll know is that type 1, I mean, there's another name for it like gravis, Ehlers-Danlos syndrome gravis. That one's considered to be more autosomal dominant. Type 2 is considered to be more autosomal recessive, but these are not tried and true by any means. Mutations are typically isolated in the collagen 5 genes, collagen 5A1 and A2. But that's only in 50% of cases, and there's another small subset of cases between these two where tenacin X is responsible to a degree, but these aren't strict rules per se. What you'll notice with this is that the skin will have some unique findings. It's hyperextendable, but it snaps back. If you have a wound, it gapes a little bit. You can have cigarette paper scars, molluscoid pseudotumors, calcified subcutaneous nodules, varicosities, and bruising. From an MSK perspective, you might have some hypermobile joints. That could delay your ability to walk, especially if when you're really young and learning how to walk. You could have recurrent joint dislocations, pes planus, genu recurvatum, kyphoscoliosis, inguinal umbilical hernias. The more complicating factor here, obviously, is the CV side effect, which is mitral valve prolapse. You could also see epicanthial folds, hypertelorism, blue sclera, so that's important to know, blue sclera, Gorlin sign, where you can touch the tip of your nose with your tongue, demonstrated here on the right. And in pregnancy, you can have some sort of prematurity because that can cause early rupture of fetal membranes and even potential postpartum hemorrhage. Moving on to type 3 now. Type 3 is also considered more purely hypermobile. It's considered to be autosomal dominant, but we don't have a good gene isolator for this one quite yet. Musculoskeletal findings of this one is all your joint laxities, recurrent dislocations, even degenerative joint disease at an early onset. You might see some minimal or mild hyperextensibility of skin. You will still have the propensity to develop an MVP, and those are all important, but it's very similar to the classic type, right? Just less skin findings in the hypermobile type. Type 4 here, vascular, is considered to be autosomal dominant, and these all can be done through DNA analysis or CVS amniocentesis. So that's just something to be aware of as well. But anyhow, type 4 is considered the vascular subset of Ehlers-Danlos, and this one is responsible, or at least the gene's responsible, is the collagen 3, specifically collagen 3A1 gene. That obviously secretes and synthesizes collagen 3, type 3 in a particular way. But skin here, the skin findings are impertinent because you can sometimes diagnose these kids from the skin findings or their overall appearance. So it's just something to be aware of. Thin, translucent, fragile skin. You can easily see the veins. Inextensible, so it doesn't stretch. Bruising present, varicosities present. You might have some joint laxity here or there. The concerning thing with vascular type and why it's so big of an issue is that you can have aneurysms, dissections, rupture of large and medium-sized vessels in AV fistulas. This can also extend to GI tracts where you have colonic rupture or recurrent abdominal pain. Pregnancy, you can have uterine rupture or arterial rupture or tearing of the vaginal tissue. The key here, craniofacial-wise, you'll have acrogeric facies. That's something I recommend you look up just to make sure that you can at least isolate how this face will look, because it can be your first clue. Lab-wise, you could do a skin biopsy for type 3 and collagen and trying to get those in culture fibroblasts. Also, you can do a two-dimensional echo, but I think DNA analysis is becoming the way of the future with diagnosing these. This one's going to need some management. Definitely some management here. So you're going to need to make sure that you're well established with cardiology and CT surge. They're going to be high-risk pregnancies. So if they're a patient with EDS type 4 and they're going to get pregnant, it's high risk. And they are to avoid, or at least it's recommended to avoid, physical contact sports for concerns of rupture. Okay? Moving on, I know we skipped a few, but we're going to go to type 6 here. Type 6 is the kyphoscoliosis type, considered to be autosomal recessive. And the pathogenesis here, the mutation is in the PLOD gene. Kyphoscoliosis, consider, things to consider. Make sure you know that the skin can be hyperextensible, joint laxity. Severe kyphoscoliosis is notable here. And the added thing that you don't quite, it doesn't quite make sense with the name or anything else, but you could have eye manifestations with this one. Ruptured globe, retinal detachment, intraocular hemorrhage, keratoconus, blindness, etc. Skin biopsy, you can do a biochemical assay for reduced lysyl hydroxylase, which is in part the enzyme secreted by the PLOD gene. They're going to need to see an ophthalmologist and potentially ortho, depending on how bad the kyphoscoliosis is, as well as oral ascorbic acid may be helpful. Moving on over to arthrochalasia, the subtype of EDS here. The mutations here are in a particular part of collagen 1A, collagen 1A2, and 1A1. The specifics is that the amino-terminal propeptide cleavage site is often defective, and that can lead to a defective conversion of procollagen to formal collagen type 1. Therefore, the issues you're going to see are going to be bony joint-like issues, right? Collagen 1 is a primary unit of bone, so you're going to see congenital hip dislocation, severe joint hypermobility, and dislocation of large and small joints. May see scoliosis and short stature as well. Moving on, we have dermatosparaxis here. That's type 7C, and this is autosomal recessive as well. And this one has a mutation in the ADAMTS2 gene. It's a recessive mutation in the ADAMTS2. Clinical findings here with the skin, you'll notice that you'll have severe fragility, laxity with sagging, redundancy, as well as easy bruisability, the potential for hernias, premature rupture of fetal membranes, and normal wound healing. And that is the dermatosparaxis type. In general, this is general here for EDS. You may have to refer to dermatology depending on the effectiveness, how affected the skin is. Orthopedic surgeons are often going to be involved here. A lot of this is joint laxity, joint issues, maybe even some sort of scoliosis. Depending on the subtype, skin trauma can lead to worse outcomes. That can lead to your fish mouth scarring, or your cigarette paper scarring, or your gaping wounds, etc. The surgeons need to know that there's a poor wound healing component to it, which they'll often figure out. And they need to also be closely monitored by OB when they're having a pregnancy in general. And here is a good photo from Spitz here to kind of help put together all the findings. Here's a nice graphic from Jane here, and it's very helpful to go through this. So let's try to go through this. As a review, classic types, autosomal dominant or recessive, that's up in the air, but most likely due to a collagen 5A1 or A2 issue, and this is going to be hyperextensible skin, joint laxity, skin fragility, fish mouth scar, cigarette paper texture, absence of the frenulum, and pseudotumors. Hypermobility type here is due to the tenacin X mutation most often, but can be also associated with others, and can have the striking joint hyperextensibility with minimal skin involvement. Autosomal dominant is what's considered. Vascular type, the most important type out of these, due to a mutation that's autosomal dominant collagen 3A, most likely. Visible veins, vascular fragility, easy bruising, maybe some hypermobility, but these ones are going to rupture their large named vessels if they get hit too hard or if they're not monitored carefully enough. Kyphoscoliosis type, just know with this type, the PLOD gene, autosomal recessive, where you have weakness in muscles, joint laxity, and ocular fragility. That's the key with this type. There's an ocular fragility component to this. Arthrochalasia, collagen 1A, collagen 1A1 and 1A2. Notice that those are bone things and joint things, so then bones and joints are going to be more affected in this than the others in terms of damage. Dermatosporaxis, this has your fragile and sagging skin. Do not get this confused with cutis laxa. And then some other lower yield ones. I will say that type 8 is a periodontal type. We don't have a good idea of the gene for this one yet, but they do have a very severe periodontitis, and that there is a spondylodysplastic subtype that's not named, but it's considered to be progeroid. The mutation is B4-GALT7 or galactosyl transferase 1. They're going to look like progeria to a degree with some EDS findings. All right, that was a lot, but we're going to keep on going with Marfan's, another high-yield diagnosis that you've probably heard of. This is an autosomal dominant mutation in the fibrillin gene, FBN1 gene on chromosome 15. And without fibrillin, you can't modify elastin quite as well, leading to concomitant defects in ocular, CV, and MSK systems. Findings here, they're going to have a pretty unique clinical picture, at least on physical exam. And that's going to be tall stature, lower body length, it's going to be longer. Upper body length, you're going to be gangly, but not longer. You're going to have, you could have arachnodactyly or dolicephaly. You could also have pectus excavatum, a high arched palate, loose joints, poor muscle tone, kyphoscoliosis, pes planus, or inguinal hernias. With the eyes, you can have an ectopia lentis, and it's key to know that the lens deviation in Marfan's is upward, because you can often confuse that with homocystinuria that has a similar finding and some overlapping syndromes or symptoms, but the lenses go downward. I don't know how tried and true that actually is, but it's definitely board fodder. The concerning thing with Marfan's is you can have a progressive aneurysmal dilation of the ascending aorta with secondary regurgitation, CHF, dissection, and rupture. You can have EPS, decreased sub-Q fat, and striae as well. Your differential diagnosis is listed here on the left, and that's often considered a Marfanoid habitus differential. You want to get an echo and chest x-ray. You want to make sure they're following with cardiology, especially if they have some concerning findings, and potential surgical repair with CT surge. Might need to see ophtho depending on the eye involvement, or orthopedics depending on the limb-leg involvement. Estrogen seems to be helpful in patients to prevent excessive tallness in females, specifically obviously contraindicated in males, so that's something one can consider. But mostly the cardiac complications is what causes death in these patients. And here is a good schematic here. Feel free to pause it to go through it if you're a visual learner. All right, moving on, cutis laxa here. There are a few different subtypes of cutis laxa, okay? It's kind of like EDS to a degree, and there's a few different inheritance patterns. The most common one is autosomal recessive, followed by autosomal dominant, which is usually skin-only manifestations, and X-linked recessive is typically an acquired mutation. So, rare disease here. The pathogenesis usually involves heterogeneous mutations in fibrillin 1, or fibrillin 5, excuse me, the elastin gene or ATP7A gene. If you have a mutation in the ATP7A gene, that impairs copper transport necessary for lysyl oxidase activity, and therefore, can inhibit normal elastin production. But the clinical severity is dependent on the mutations, and they all contribute in different ways. You're going to notice the hallmark findings, which is loose, redundant, pendulous skin folds, kind of looks like a hound dog, maybe a Shar-Pei, inelastic skin, lacks recoil, so it doesn't snap back. You can have a deep, hoarse vocal cord laxity causing your deep voice. Lungs, for newborns, you might have a hypoplastic lung. Emphysema might even be noted, but that's usually with the autosomal recessive disease, and that can have those overarching secondary sequelae like tachypnea, pneumonitis, and cor pulmonale. Other clinical findings, you can have gastrointestinal findings like esophageal, duodenal, rectal diverticulae. GI-wise, you can have a bladder diverticulum. So just notice that there's some outpouchings, obviously, which is consistent with epithelium that is stretching and inelastic. MSK, you can have inguinal, diaphragmatic, or umbilical hernia. Again, inelastic layers of your body, as well as hip dislocation, And in the X-linked disorder, you can have a occipital horn. Differential diagnosis here includes PXE, EDS, granulomatous slack skin, DeBarcy, scarf syndrome. Skin biopsy can show decreased elastic fibers, especially when you stain with a Verhoeven von Giessen stain. Serum copper and ceruloplasmin might be elevated depending on your type of mutation. Chest X-ray can be helpful in terms of diagnostics, especially for that secondary lung sequelae. They might need to see plastics to help kind of repair some of the cosmetic deficits from this disorder. Referral to pulmonology, GI, urology might be helpful if any of those parts of the body are symptomatic. There's a great variability in the severity, so sometimes you can have death in the neonate, depending on how bad the lungs are, or you can have a normal lifespan, which is kind of interesting. And here's an example here. On the left, the patient is only 23. Looks a little bit older than that, obviously, and that's just from the inelastic skin. And here's some other depictions of the sequelae here. All right, we're moving on here. PXE. This is often a autosomal recessive disorder, but can be autosomal dominant as well. The gene mutation is in the ABCC6 gene, and that is a transmembrane transporter gene, ABC transporter gene. A DNA mutation analysis, if the defect's unknown, can help you find this out, and this is a pretty rare disorder. Usually you start to see this in your childhood, but you can also see it present in your second, third decade of life. The mutation in the ABCC6 gene is also a multi-drug resistance protein, and because you're not effectively shuttling parts of cellular material inside or outside of the cell, you could have mineralization of the elastic tissues, and this can affect areas such as the eyes, skin, and arteries. Differential diagnosis here includes cutis laxa, and since there's angioid streaks, you can have an angioid streak differential here. Sickle cell, Paget's, hyperphosphatemia EDS, which we did not go over because it's pretty lower yield, but it's good to know there are some angioid streaks associated with that subtype specifically. Laboratory data here. Skin biopsy can be helpful to a degree, especially if you have the von Giessen stain for the elastin fibers. Fundoscopy can be helpful for ocular findings, finding the angioid streaks, and X-ray can help for the extremity or abdomen if you have a symptomatic finding with that. The skin, here you're going to notice these yellow papules, usually on the neck, but can be anywhere, any skin folds, and they're going to form a cobblestone-like plaque. So these papules are going to coalesce into a plaque that is just kind of cobbly. It's going to look like what's called plucked chicken skin. You also see that soft skin folds are noticeable on the neck's axillate, antecubitum, abdomen, groin, and thighs. The mucous membranes will also have yellow papules on them. This can include the soft palate, the labia, rectal, or vaginal mucosa. But back to the eyes, we're talking about those angioid streaks again. These are ruptures in the brush's membrane, secondary to elastic fiber defects. Macular degeneration, optic drusen, retinal hemorrhage all can cause blindness as well. Modeling of the retinal pigment epithelium can also be noticed as well. There are some CV findings with this, and that includes gastric artery hemorrhage, claudication, hypertension, angina pectoris, MI, CV accidents, mitral valve prolapse. They are at an increased risk of miscarriage and are at an increased risk of cardiovascular complications during pregnancy. These patients will need a complete physical exam and regular follow-up with their PCP, as we all do, but even more stricter follow-up thereafter. Referral to dermatology and ophthalmology can be helpful for some of the skin findings and maybe the help with the diagnosis. Ophthalmology for the ocular findings, which can be devastating in this case. GI, cardiology, neurology if you're symptomatic. There may be some cosmetic correction needed for the skin manifestations. They should be seen by a high-risk OB during pregnancy and get counseling for that. There's suggestions that you should restrict your calcium intake, and that's up for debate and not a hard recommendation at this time. And examination of the first-degree relatives should be done. Here's some example of the findings of the skin here. Lots of wrinkled, soft, redundant skin here. Here's an example of an angioid streak here on the right, which has its own differential that was shown a few slides back. So redundant skin, angioid streaks, yellow papules, CV accidents, MVP, cardiac complications, peripheral artery disease, and bleeding from the GI tract. All right, moving on, we're going to talk about OI, osteogenesis imperfecta. This is something I've seen in med school for sure, and it's going to be a nice review. There's several types here, all ranging mostly autosomal dominant, but some recessive components as well. You can do DNA mutation analysis on this. The incidence of this is more common than other genoderms we talked about, and type 1 is the most common. The age of presentation depends on the subtype. Overall, what you'll notice is that heterogeneous genetic mutations in genes encoding type 1 collagen can be noted, and these are heterogeneous phenotypes. Mutations that alter the amount of collagen produced are more likely recessive phenotypes, and mutations that change the structure of type 1 collagen can be mild to severe phenotypes. Clinical findings here, the skin is typically thin, usually you have decreased elasticity. You can notice easy bruising, and that's specific with the 1 in 4 subtype. You can see blue sclera in up to 90% of your patients with all these subtypes except for type 4 commonly. You can also see hearing loss secondary to otosclerosis. Type 1, in terms of variability in the MSK findings, type 1, you can have fracture or bowing of the long bones, joint laxity, or kyphosis. Type 2, you might notice multiple fractures in utero, and this type is the most likely to pass away during birth or in utero. And just listen to these. I mean, just sounds severe, right? Multiple fractures in utero, newborn with beaded ribs, crumpled humeri and femori, frontal temporal bossing, limb avulsion during pregnancy. It just sounds sad, honestly. So this is their most severe type. Type 3, fractures in utero at birth, but not as devastating as the previous. May have a kyphoscoliosis, as well as bowing with crippling deformities. Type 4, fractures at birth and childhood with decreased frequency at age. You could see dentinogenesis imperfecta. That's in your type 1, type 4 most notably. You can see mitral valve prolapse, aortic valve disease in type 1. You might see valvular disease in type 2. That's cardiac valvular disease. Differential diagnosis. You got to think of child abuse. It's something that I forget about personally. You're so ready to look for the unicorns on all these dumb genoderms because you learn about so much of them and you forget about child abuse. So remember child abuse, okay? Easy bruising, easy broken bones. Think child abuse first, okay? Now I got off that soapbox. Laboratory data, you can see bone films, echocardiograms, and audiology. You'll have to refer them to where their symptoms are. You could consider intranasal calcitonin or bisphosphonates once you do a risk-benefit and decrease the incidence of fracture, hopefully. Like we talked about, type 2 is most likely to have a perinatal death period. Type 3, you're going to have increased mortality in the 3rd and 4th decade due to cardiorespiratory failure, and limb deformities after fractures are noted as well. Here's some examples of patients here. The blue sclera is noted here on the leftmost picture. The middle picture is severe bowing, kyphoscoliosis, and crippling deformities. And on the right, you can even see this is probably a type 2 patient, crumpled humeri, femora, with abducted thighs at 1 week of age. Here are 2 pictures, one for type 1 more so than type 2. The inheritance of Busch-Gildendorf syndrome is autosomal dominant. The mutations most likely thought to be in the LMD3 gene. This can be heterozygous and a loss of function germline mutation. Incidence here is rare, might be underreported because it's kind of can be asymptomatic to a degree, or the lesions can be undiscovered. Pathogenesis here is usually an increased elastic fiber content, increased elastin mRNA levels in fibroblasts, but there's an unknown defect linking the bone and skin. What you'll notice though is dermatofibrosis lenticularis disseminata, which are skin colored to yellow dermal papules with or without coalescing plaques. They can be in symmetric distributions on the trunk, buttocks, arms. Usually you can see them also on the lower limbs as well. And this is usually just a cosmetic concern. You can also see osteopoikilosis, which is a 1 to 10 millimeter well circumscribed round to oval opacities within usually carpal tarsal bones and maybe even in the phalanges as well. You could also see them more in the epiphyses and metaphyses of the long bones. Differential diagnosis for this includes TSC, PXE, and familial cutaneous collagenoma. You could get an x-ray of the hands, feet, and knees for bone lesions, and they might be noted as having spotty bones. Um, and that, obviously that could be misdiagnosed by radiologists, so it might be something to input in your clinical exam or clinical history too that you're concerned with that. You can do a von Giesen sting for evaluating your elastin. Management here, it's a benign condition. It's pretty easy to deal with. Most of everything is mostly congenital in concerns. It's a normal lifespan. It's got variable expression but a high penetrance. So you might see skin alone, you might see bone alone, you might see both, even within the same family. Here are the DFLD, dermatofibrosis lenticularis disseminata, as well as the osteopoikilosis. All right, moving on, we have focal dermal hypoplasia. You might also see this named as Gault syndrome. And this is a genetic disease of multiple systems, in fact, initially affecting skin, skeleton, dental, eyes, and face, with also facial abnormalities or dimorphisms. And we just felt that was the best way to put that in a perspective, so we use that quote. Inheritance here is X-linked dominant. The gene is obviously the XP22.31. It is 90% female because it is lethal in males, but some males might have a half chromatin mutation, so you can rarely see this in men, but mostly going to be females. Pathogenesis is mostly due to the porcine gene, PORCN, and we can diagnose this now with DNA analysis. And how it presents is these asymmetric, atrophic, hyperpigmented, or hypopigmented telangiectatic linear streaks in lines of Blaschko on trunks and extremities. You could also see soft red to yellow nodules or fat herniations. You may even see ulcers or congenital absences of skin. You also can see papillomas on the lips, perineum, maxilla, and periumbilical area. Other key features: hair might be sparse, more brittle with a patchy alopecia. Nails might be absent or dystrophic. Eyes might have a columboma or strabismus or microphthalmia. MSK-wise, you could see syndactyly, polydactyly, oligodactyly, or even a lobster claw deformity. So notice right here, focal dermal hypoplasia, Gault syndrome has Blaschkoid presentations and lobster claw deformities. You could also see osteopathia striata, which are vertical striations in the metaphysis of long bones, and short stature. Here's a great example of the lobster claw. Here's a great example of osteopathia striata. You could see hypodontia, oligodontia, small teeth, or dysplastic enamel. You can see small rounded asymmetric facies, notched nasal ali, mandibular prognathism, or mild mental slowing. Differential diagnosis here includes IP, and that's from mostly in part of the blastoid distribution, as well as venous lipomatosis superficialis or Rothman-Thompson syndrome. Skin biopsy might help show a normal or thin epidermis over an intensely hypoplastic dermis with adipose tissue on the epidermis. So basically what that is saying is you're going to see less dermis and high-riding fat on pathology. And this is actually one of those genoderms where there's a strong pathological correlation. You might get tested on this from a pathological perspective. Management here: referral to derm, ophtho, ortho. You can also referral to dentists with the onset of oral disease. You can elicit a family history to see if there's any history of spontaneous abortions, miscarriages, or stillbirths. That might show you that there were some males affected potentially. These kids can be severely handicapped, especially with the degree of skeletal formation deformities they might have. There's cosmetic impacts as well, but otherwise pretty normal lifespan. So here's a good photo showing papillomas, short stature, sparse hair, some of these Blaschkoid-like hyper or hypopigmentations, telangiectasias, fat herniations, and lobster claw. And now we're going to move on to lipoid prognosis here. This is autosomal recessive inheritance gene mutation is the ECM1 gene. Now, here's a good little cute little thing just to kind of help round out your derm knowledge. ECM1 is the gene mutation in this disorder, which is not to be confused with ECM3, which is the antigenic target of lichen sclerosus. So that's just something to be aware of here. Incidence is low with an increased incidence in South Africa. These patients can also have a hoarse cry at birth, like what other disease? ... Cutis laxa. That's right. Pathogenesis here is a mutation in ECM1. Obviously, prenatal diagnosis is going to be the way of the future with DNA analysis. Skin lesions, early on, you're going to see bullae with residual atrophic scarring on the face, neck, and extremities. However, late, you're going to see yellow papules, nodules on the face, neck, extremities, and the very interesting finding of monofiliform blepharosis, or the string of pearls along the eyelid, especially where the eyelashes pop out. You can also see verrucous nodules of the elbows, knees, and hands. You might see a patchy alopecia in the scalp, beard, and eyelashes. You might also see infiltrated yellow papules on the mucosal lip. You might see a hoarse cry as well as large wooden tongues. You could see temporal and hippocampal calcifications on MRI or CT with or without seizures. And therefore, with these calcifications, there is a chance of neurologic manifestations such as epilepsy, dystonia, and spontaneous CNS hemorrhage. You can also see bilateral symmetric comma-shaped calcifications of the amygdala, which is typically pathognomonic for this disease. Things you can do amyloidosis stains, so you can stain Congo red to help you differentiate from other disorders, as well as erythropoietic protoporphyria can present very similarly. You can also consider PXE and xanthomas. And head imaging is going to be very important for this because the calcifications can help give away the disease right away, depending on the pattern. There is a concern that retinoids, or suggestion that retinoids or oral dimethyl sulfoxide might be beneficial. And the effectiveness is in treating cutaneous and laryngeal lesions by decreasing the amount of hyaline deposits using systemic retinoids. Ultimately, they might need a very aggressive correction of the vocal cords, maybe even tracheostomy, depending on how flaccid the larynx and trachea are. Referral to derm might help with diagnosis as well as some of the cosmetic outcomes. Referral to neurology might be necessary if symptomatic or if concerns arise on imaging. This can potentially affect internal organs, but mostly have a normal lifespan. So here on the leftmost photo, we'll see facial scarring as well as the yellow infiltrated papules with the eyelids. And if you look really closely, you can see the eyelids there. You can also see verrucal nodules in a linear pattern on the fingers. And the CT scan here shows symmetric calcifications just lateral to the dorsum sellae. Now, progeria. Progeria is one that you might have heard for sure. And this is a genetic disease that basically can be coined as Benjamin Button syndrome type disorder, and that is looking old at a young age. Also known as Hutchinson-Gilford syndrome. Inheritance here is sporadic, autosomal dominant, and it's the lamin A gene that is often implicated in this. It is a rare incidence, up to 8 million, or 1 in 4 million, 1 in 8 million. Slightly affects males more. Prenatal diagnosis can help with DNA analysis. Mutations in the lamin A gene, so lamin A and lamin C are the protein products of this gene, and these contribute to the structural scaffolding of the nucleus. De novo dominant mutations in the gene, also gene encoding lamin A, lead to this downstream nuclear scaffolding defect. Skin findings here, you see thin, atrophic, shiny plaques in areas, but might be wrinkled and dull in others. Prominent scalp with thigh veins as well. So you might see scalp veins, you might see thigh veins. You're going to lose a lot of your sub-Q fat. You might notice a mottled hyperpigmentation, sclerodermoid changes on the lower trunk and thighs, as well as the same sclerodermoid or scleroderma-like tautness. Hair might be noticed as sparse or absent, especially including eyebrows and eyelashes, but you might still have vellus or downy hairs. Craniofacial wise, you're going to have a large cranium relative to your face with frontal and parietal bossing, a thin beaked nose, if you will, small ears without lobules, micrognathia, prominent eyes. And these findings might start out as normal at birth, but be noticed as you go through the first or second year of life. Ultimately, these kids will have a failure to thrive, and they're going to look overtly small for their age. Like, for example, their height at 10 years old might rival that of a 3-year-old. They'll have osteoporosis, prominent joints on extremities, as well as muscular wasting. CV-wise, you'll see premature severe atherosclerosis with angina pectoris, CVAs, CHF, myocardial infarctions. You might notice that there is an abnormal and delayed eruption of permanent teeth, a high-pitched voice or squeaky voice. Psychosocially, there might be some severe problems related to the appearance and self-image. Differential diagnosis will be your progeroid differential, other things that might present with similar symptoms here. And that includes Cockayne, Werner's, or Hallermann-Streiff syndrome. You could notice that a urinary hyaluronic acid is increased, but DNA analysis will pretty much isolate your diagnosis here. These kids will pass away early, unfortunately, usually in the second decade of life, and it's most likely going to be from an atherosclerotic complication or cardiovascular complication. You could treat with the new drug mentioned here, either alone or together with bisphosphonate or cylindronate or pravastatin, and that might have some increased chance of survival, but it's not fantastic by any means. And here's a good picture depicting all of the hallmark clinical appearances. You can see some of the sclerodermoid tautness here of the legs. You can see frontal and parietal bossing with sparse hair and prominent cephalic veins. Werner syndrome here is characterized by premature degeneration of major organs. Patients often develop scleroderma-like skin changes, and the major skin problems relate to chronic ulcers that require meticulous care. This is caused by the WRN gene, which is a DNA helicase gene, but is considered to be the progeria of the adult, and that's hence why it's in this chapter, okay? Considered autosomal recessive. The WRN gene was named after the disease, Werner, but now has been renamed to the RECQ-L2 gene, or RECLIL2. DNA analysis will help isolate that. There's a slightly higher incidence in Japan, but still present throughout the continent and world. But overall, you'll notice that the presentation is anywhere from the second to fourth decade of life. The mutations in the RECQL gene encode the DNA helicase, which defects in that lead to increased frequency of recombination with predisposition towards accelerated aging or cancer. You'll notice that there's sclerodermoid changes, just like the last one, mottled hyperpigmentation, just like the last one. You might notice soft tissue calcifications and leg ulcerations, which is a little more unique to this disorder. Circumscribed hyperkeratosis, especially over bony prominences, and loss of sub-Q fat. You might notice that they have bird-like faces in this one, just like the last, as well as taut circumoral skin and inelastic ears. You'll have ultimately short stature, muscular wasting, pes planus, osteoporosis, osteoarthritis. You could see a posterior subscapular cataract. You can have your high-pitched voice again, and premature arteriosclerosis, maybe even diabetes and hypogonadism. You can have premature hair loss, and there is a concern for neoplasm in this disorder too, so you could have fibrosarcoma, osteosarcoma, cutaneous carcinoma, meningioma, adenocarcinoma, increased risk of thyroid carcinomas and melanomas, particularly in the Japanese patients that have this. Differential is going to obviously be progeroid to a degree. Myotonic dystrophy is going to be included here because of its somewhat more delayed presentation. Ultimately here, your premature death is going to be from malignancy, but it can include MI or CVA, and that's usually by your 4th to 6th decade. So your average lifespan in this disease is more along 50 years, where True progeria is more along 10 to 20. Treatment here, you'll have genetic counseling, which should be provided. You could treat skin ulcers aggressively and early, and might even need skin grafting. Sometimes you can help use etidronate as a modification for painful soft tissue calcifications. Vitamin C might be helpful for to reverse age-related metabolic abnormalities, but that's typically from a mouse model and hasn't been proved in humans quite yet. Here are some examples of your findings here. And notice you're going to have your loss of fat here in the premature age appearance, and a good example of osteoarthritis with subcutaneous calcified nodules on the right. All right, moving on, we have aplasia cutis congenita here. This can have various inheritances. You can diagnose this with ultrasound as well, and ultrasound is going to be more of your go-to. The pathogenesis is specific for the subtype, so it's hard to kind of narrow down exactly here. But it could be genetic, it could be trauma, it could be teratogen, it could be infection, and those all cause a localized absence of one of the following: epidermis, dermis, subcutis, with or without underlying bone. Key features here: with aplasia cutis congenita, you're going to notice a small, maybe even the large, solitary or multiple well-demarcated superficial erosions, 2 deep ulcerations with thin membrane or atrophic scars, and this can sometimes have alopecia in that area that's effective as well. Basically, this will heal with the scar to a degree. Larger lesions, usually the deepest, with possible extensions to the dura, are at increased risk for meningitis, so be aware that you could have an absence of bone, exposing CNS effects to the environment, CNS components to the environment here. And to break down the groups here, group 1 is your autosomal dominant or sporadic, and that's usually when you just have scalp aplasia cutis congenita, period. That's it. Group 2, autosomal dominant, here is where you have scalp aplasia cutis congenita with associated limb abnormalities. You might even see hypoplastic or absent phalanges. Hands and lower extremities can be affected as well. Group 3 is more sporadic, and that's usually aplasia cutis congenita on the scalp associated with epidermal or organoid nevi. Epidermal organoid nevi might even be finding corneal opacities, mental retardation, or seizures. Group 4 is going to be embryonic associations with aplasia cutis congenita. Group 5 is going to be ACC with associated fetus papyrosis or placental infarcts. So therefore, you might have, in this disorder, group 5, multiple symmetric stellar or linear aplasia cutis congenitas, and this is going to be more trunk or extremities rather than the others being previously on the scalp. You might even notice group 6 here. You might have aplasia cutis congenita associated with EB. Group set, and I don't think it's high yield to memorize all these. I'm just doing this for completeness sake, so just be mindful. I would not waste my brain space trying to memorize each type of ACC. That being said, here's each type of ACC continued. Group 7 being associated with, on the extremities, ACC with blistering, without blistering, excuse me. Group 8, you'll have ACC caused by teratogens or intrauterine infection. And the most common one you've learned from med school is methimazole. Here, you can also have torch infections such as varicella or herpes that can cause these as well. Group 9 is usually ACC associated with a chromosomal malformation syndrome. This can include trisomy 13, 4P syndrome, ectodermal dysplasias, focal dermal hypoplasia, amniotic band syndrome, and chromosomal 16 through 18 defects. You might notice that there is a erosion, ulceration, scar, or membranous defect covered by a thin epithelial membrane. You might notice hair color sign where you have a pronounced darkening of the hair and a ring around the lesion on the top of the scalp. And in that area, you will have absence of markers for neural crest or the neural tube. Your differential is pretty broad here, so be aware of that. It can be very easy to get these confused with something else. Laboratory data here, you probably should get a skin biopsy to diagnose. Be wary that if there is concerns for extension into the CNS that you might want to forego skin biopsy. MRI, especially in lumbosacral areas where those ACCs are present, might be helpful as well to see if there's communication. Cranial ultrasound can screen beneath the ACC in infants, especially with an open fontanelle. Management here, you're going to go to derm, you're going to go to plastics, and you might need to see a specialist more specific for your phenotype. The prognosis here includes most lesions healing within weeks to months, and it ultimately leaves a hairless, smoothless, yellowish, atrophic scar, unfortunately, but it does heal. And here's a good example of where one would be. Here are some examples of them healing more secondarily, and more severe ones compared to others. And here is the bibliography, a lot of things we use to help kind of put together this PowerPoint. If any questions come up, leave them down in the comments. Again, thank you for taking a look at this with us. Hopefully you're getting something out of this, and we'll see you in the next one.